Welcome. I'm Don Hood, and this is a symposium that is part of the eyeRISE virtual Congress sponsored by Topcon Healthcare. The topic today is OCT and glaucoma diagnosis. Now, I've had over 10 years experience helping clinicians interpret OCT images, but I'm not a clinician. However, we're fortunate today. With me, we're going to have two outstanding clinicians, I think, who are well known to most of you. First is Dr. Murray Fingeret. He's clinical professor at the State University of New York, College of Optometry. Murray was recently inducted into the National Optometry Hall of Fame. He has many awards and honors, and I'm not going to read them, but one that's particularly relevant to today's program is he was awarded the Vincent Ellebrock Clinician Educator Award in 2013. He's also a founding member and past president of the Optometric Glaucoma Society and currently the president of the Optometric Glaucoma Foundation. Our other expert is Dr. Michael Chaglasian, associate professor at the Illinois College of Optometry and also chief of staff of the Illinois Eye Institute. He too is a founding member of the Optometric Glaucoma Society and is currently its executive vice president. In addition to being outstanding clinicians, Murray and Mike share a passion for educating clinicians that will be very apparent to you in the next hour or so. They're also great people to work with, so we are really fortunate to have them with us today. Thank you, Mike, and thank you, Murray. Okay, so let's start with the tutorial. So I'm going to describe an approach to understanding and detecting glaucomatous damage. And first, my obligatory financial disclosures. I have grants from both Topcon and Heidelberg, as well as equipment. Now, I'm going to address two questions in this brief tutorial. First, what should I look for in an OCT glaucoma report? And second, where can I find it on my particular instrument? This approach that I'm going to describe and the reports I'm going to describe really were based upon a one-page report for detecting and understanding glaucoma that a student, Ali Raza, and I developed in 2014. At that point, it was based on our experience of helping clinicians with OCT for about 4 or 5 years in 2004, by the time we got to 2014. All right, so here's the one-page report. In this case, it's based on 2 cube scans. One cube scan here is centered on the disc. The second is centered on the fovea. You'll see in a couple of minutes that the important point here is that the OCT scan covers both the macula and the disc. And in some cases, you can do that with a single scan. All right, so this is really more than just a report. It's a process or a method, and I'm going to talk about 4 principles or rules that we use. The first rule is you want to examine the circumpapillary B-scan image, and you want to examine it for glaucomatous damage and as well as segmentation errors. So if we blow this up here, it should be large enough and of clear enough resolution that you can see whether the segmentation is accurate, as indicated by the green lines here, and whether there's damage, as you can see locally right there, right? Now, there are 2 ways you can get this particular image. You can actually get it from a circle scan that's scanned around the disc, or more commonly these days, you can get it derived from a thickness plot. So you can get it derived from this here, for example. And again, you're going to be looking for segmentation and image quality, how well the lines segment this, and you're going to be looking for damage. Excuse me. Okay, the second rule. You want to look at ganglion cell and retinal nerve fiber layer probability, or sometimes called deviation maps. This is essential. So these maps are based on thickness maps, which are also useful. And let me remind you of what a thickness map is before I tell you what the probability map is. So from this cube scan here centered on the disc, this is one of the B scans that make it up. We're going to get retinal nerve fiber layer thickness. And this is a pseudo color plot here of the thickness. And the way you read this is red is thick and blue is very thin. From the cube scan centered on the macula, or the fovea, we're going to get both retinal nerve fiber layer thickness and ganglion cell thickness. So that's retinal nerve fiber layer thickness, that's ganglion cell thickness, and again, dark red is thick, blue is thin. Right now, to get a probability or a deviation map, what the software does is it compares these thickness maps to normative control values. So when you compare this to normative control, you get a probability map here. And now red is bad. And in particular, red means abnormal at the 0.1% level, and red would be 1%, green, yellow would be 5%, and green's within normal limits. We're going to flip this along the horizontal meridian, just the way the image on the back of your eye is flipped, to get a field view. So that damage there corresponds to this damage here, right? And the reason for this is we're going to compare later on this damage to visual field points. So there are the locations of a 10-2 visual field. Okay, so this is the probability map for the ganglion cells. This is the probability map for the retinal nerve fiber layer. And again, these are in field view. So this is based on this and this stitched together, field view. And again, dark red is highly significant at the 0.1% level. Green would be within normal limits. And then this, as I've already described, it is the ganglion cell thickness map. All right, rule number 3, you want to look for topographical agreement of glaucomatous damage within a report. So let me unpack that. What we're looking for is something that's characteristic of glaucomatous damage, and that is typically an arcuate. So I want to remind you that because the axons from the ganglion cells arc around the fovea when they enter the disc, and because glaucoma acts at and in the disc, damage here creates this classic arcuate kind of pattern. So you're going to be looking for damage that's arcuate in nature. The second, which I'll define better in a moment, is everything should agree. That is, the different parts of this report should agree. Now, to make that easier, what I'm going to do, or what we recommend, is that this get presented in an N-stin plot, where T stands for temporal, and that's the middle of this. So you might say, what's an N-stin plot? All right, so let me take a moment to describe that. So in a sense, what you're doing is if this is the center of fixation here, and this is an 8 degree, plus or minus 8 degree circle, this is plus or minus 8 degree on your thickness plot. To understand this, let's go back to what you're more used to. What you're used to, starting with the very earliest Zeiss reports, is what's called an N-SNP, a T-SNP plot often. And that is called a T-SNP plot because it is plotted the way the scan goes, which is from temporal, T, to superior, S, to nasal, N. You get the picture, T-SNP. The problem with this particular plot, when you're trying to understand the relationship to topographical parts of the retina, is that it splits the macula in half. So that's plus or minus 8 degrees now split in half. Whereas if you plot it as an N-SNP, that is, you plot it as if it starts in nasal. So now it goes nasal, superior, temporal, inferior, nasal, N-SNP. Now the macula is in the center of the plot. This is the temporal half of this region, which I'll show you in detail in a moment, would represent on your visual field about plus or minus 15 degrees plus the nasal step. So here's a little diagram. This is the region that represents the macula, which is plus or minus 8 degrees. This is the temporal half here. So this is the temporal half. And that temporal half represents about plus or minus 15 degrees plus the nasal step. So let's go over here. And this is the region of the retina that's represented by this region here. And so if you put on the 24-2 visual field points, you can see that the temporal half is about plus or minus 15 degrees plus the nasal step. Okay, so back to this. We're looking for damage that is arcuate in nature, and everything should agree if it's glaucoma and not an artifact. So what everything should agree is in this, let's use this as an illustration. You can see that this is thin. This is the region that's being affected by glaucoma here. Right? That region corresponds to this here and corresponds to an arcuate that looks like something about like that. So this location here is topographically identical to this location here, is identical to this location here, and is associated with this arcuate. Okay, the final rule is if you want to compare the visual fields, which is one of the main clinical objectives, you want to use probability and deviation maps from the 24-2 and 10-2. You do not want to use visual field metrics such as mean deviation, pattern standard deviation, or glaucoma hemifield tests. So let me give you an illustration. Here's the 24-2 for this patient. You can see there's a nasal step here. You know, these are the points that are abnormal here, right? And you can see it's consistent with an arcuate, right? But notice this can miss macular damage. This is why it's so important to get 10-2s. So here's the 10-2 for this patient. You can see some damage here, right? We'll put the points over here, add the abnormal regions, add them here. And you can see that in this case here, and this is not atypical, that you've got clear macular damage confirmed on a 10-2 that's being missed by the 24-2. Anyway, rule number 4, don't compare metrics, compare probability maps. Compare this to this. Now you might be saying, but wait a minute, aren't you assuming that we can compare abnormal regions? And I would say, yeah, that's what I've been saying. And you might say, well, wait a minute. I've been taught that structure comes before function. Well, the truth is that is not technically correct. If you use probability maps like this for both ganglion cells and visual fields, and if you compare it to local abnormalities on the field, then structure function agreement occurs in the overwhelming majority of eyes. All right, so that's the answer to the first question. The answer to the second question, I'll be brief because we're going to review this in our next section. And that is, where can I find this on my instrument? So we're going to be showing reports in a moment from 3 different manufacturers. We're going to be showing a report from Zeiss, a report from Heidelberg, and a report from Topcon. So let's do the Topcon first. The Topcon report, which is called a 3D wide field glaucoma report with visual field test points, or the hood report, is available for the Maestro instruments and for the Triton outside USA. And it's based upon our lab report. It's also based upon a 9x12 single scan. So this 9x12 scan includes both the macular region and the disc. If we take one of the B scans and blow it up, what the algorithm does is measure retinal nerve fiber layer, it measures ganglion cell layer, and it produces this report. This circular image here is derived from the same cube scan. Okay, so again, this is in NSTIN, so that if we blow this up, you'll see this is your macula plus or minus 8 degrees. This is your temporal half, which is plus or minus 15 degrees plus the nasal step, NSTIN. So remember, rule number 1, you want to examine this for glaucomatous damage and segmentation errors. There's some damage, and you can see there's no segmentation error to speak of. Rule number 2, you want to take a look at ganglion cell and retinal nerve fiber layer probability maps. So again, let's review. This is the thickness map. This is the probability map for the ganglion cells. This is in retina view. This is flipped along the horizontal to be in field view. This is the thickness map for the retinal nerve fiber layer. This is the thickness map. This is the probability map for the retinal nerve fiber layer. Rule number 3, we're looking for topographical agreement of glaucomatous damage. And all of these red arrows are topographically identical points. So we should be seeing similar things. Red here, defect here, thinning here, thinning here. These black arrows are also topographically identical, and they're consistent with the arcuate that's associated with the red arrows. And we'll come back to that point more than once. All right, the Heidelberg report, also based upon our lab report. There's a US version, and then there's a version available outside the US. We're going to be presenting this one because it's got the probability maps. So again, retinal nerve fiber layer thickness map, retina view, ganglion cell thickness map, retina view, NSTIN plot. You can see the same places with agreement. This is the same eye. All of that's in retina view. Over here in field view, we have the retinal nerve fiber layer probability map and the ganglion cell probability map. The one thing that Heidelberg does differently that's different than the Zeiss and different than the Topcon is, in addition to showing significantly thinned areas, it shows significantly thick areas. So the other maps, this would be 1%, this would be 5%, and this would be 5 to 100%. In this case, they show significantly thinner. So if you want to make this, if you want in your mind's eye, if you want this to look like the plots I've just been showing you, turn all these to green. Finally, the Zeiss report, right? This is the one that you're most used to. It doesn't include the ganglion cell scan. There's a separate ganglion cell report that I'll show you in a little bit later. But for now, I just want to tell you we're going to be using the Zeiss Panomap because it has some of these same characteristics. In particular, this is based on 2 cube scans. This photo is not from the same eye. And so so you get thick, this shows you the retinal nerve fiber layer thickness map for these 2 cube scans. So that's the thickness, retinal nerve fiber layer thickness associated with this scan. This is the one associated with that scan. And here are your deviation probability maps. Now, it's a little tricky because the deviation probability map combines a retinal nerve fiber layer probability map with the ganglion cell probability map. And we'll review this again when I show you the first case in a couple of minutes. This is a derived circle scan, just like I was telling you about in TSNIT. I believe the software now allows you to click a toggle and get instant. All right, so we'll review those reports again in a moment, but this wraps up my tutorial. I just want to mention my collaborator of 10 years, Gus Demores, and all the examples here actually come from a data set he's been working on, and the patients were referred by our colleagues at Columbia. Here are two short reviews that we wrote for the clinician that's available. And here are two longer reviews if you're really a glutton. And then you can visit my website and actually get these papers, but also recorded lectures that I've done in the past. Okay, so let's take a look at some of these questions. So here's the first question that actually came in. We'll just take this first since it was first. How do you deal with the presence of macular disease when looking at the instant plot? And that there are probably two questions here. One is a clinical question, which I think we'll save for the clinical sections. In terms of identifying this damage, if you go back and take a look at the slides that show images of the report, you'll notice that the center of the instant plot is the macula region. It has a border or arrows that are magenta and blue, and then there are circles on the probability and thickness maps that correspond. So you can look for corresponding damage. All right, question number 2. What do you think should be used to determine whether a visual field is, or do you think OCT should be used to determine whether a visual field is necessary? That is a sensational question. So I'm going to give you the answer from the point of view of an OCT expert who advises clinicians. And what I'm telling clinicians and what Gus Demores is telling clinicians is if your workflow allows it, do an OCT first, and then decide whether you need a 24-2 or a 10-2. Whether you do without a visual field or not really depends on the nature of the practice or your purpose. For screening purposes, we believe you can do a very good job screening just with the OCT. In clinical practice, there may be other reasons for doing the visual field other than simply diagnosis at input, such as progression. Murray or Mike, do you want to add anything to that?
Yeah, so I would first look at that question. It says, do you think OCT should be used to determine whether a field is necessary?
Right.
From a clinical standpoint, the challenge that we often have is when we see, for example, a suspicious disc. Is it glaucoma or glaucoma suspect, or is it simply physiologic cupping? One of the things that the OCT can provide right off the bat is to understand the disc size and the chance that it may simply be a large disc, large cup. And then if you see the nerve fiber layer being full. So, if there are ways that you can use the OCT to kind of triage whether, the person even is going to escalate to the next level. As well as, you can always monitor with the OCT.
Can I just interrupt you just for a second, Mary? Sure. You also have the circumstances, don't you, where you have a suspicious looking disc and now the OCT looks sensational.
Yep.
Any reason to get a visual field on that patient?
Well, yes. I mean, I'm a real, I look at the field as another tool, to monitor over time, as well as the medical legal issues. The reality is in this world, people are diagnosed both with structure and function, and fields are important. I think the OCT can minimize the number of fields that we have to do, but you still, you can't just because, in other words, I look at the corollary of this and that people say, well, why do I need to do fields now that I have an OCT?
Right.
Not understand. And that drives me nuts because that's,
I think what we can probably agree on is that the OCT is and will decrease the number of fields that have to be done. And it's an open question, and we probably would have different predictions as to how rapidly that's going to change and how drastically the reduction will be. Mike, did you want to add something?
Yeah, I think, just to clarify a little bit, well, I agree with exactly with what Murray said, but for someone who is, let's say, a true glaucoma suspect, and you're going to follow them over time, having those baseline fields comes to be a great advantage. So if it's a sort of, less suspicious, lower risk patient who you want to do a scan on an OCT scan and everything is perfectly normal and there are not a lot of other risk factors, then I think it's probably fine, to determine that you don't need a field. But if in the back of your head there's a family history or there's other risk factors, then you want baseline field at some point in time and build from there.
Good. Okay. I think we should probably move on so we have time for the other questions, but that's great. We always come back to this if we have time. So here's an interesting question. Are OCT findings on the nasal side of the disc relevant for glaucoma diagnosis? Now, I can tell you, I've looked at hundreds, probably thousands, and finding damage that is strictly confined to the nasal is very rare, although I saw one yesterday. And so there are two questions here, I guess. One is, does it occur? And the answer is yes, it can occur, but I say rare. And then the question is, how do you treat that in terms of from a clinical point of view? And Mike?
Yeah, I think it's a lot more common to find artifact in the red disease, as we call it, on the nasal side of the disc.
No question.
So you have to be really careful about interpreting that. And I think if we learn from your tutorial, Don, it's spend more time on the enstin and the superior temporal and inferior temporal regions and look a lot at those and don't get misled by what's on the nasal side.
I'm so glad you reminded me of that. So 2 points. One is, remember, your 24-2 pretty much is the temporal half. It's a little bit of the nasal half. And the second is, when I say it's rare, I am not willing to call that abnormal unless I have a good circle scan and I can see that the layer is thin and the vessels are sticking up on the image. Just having it read on a probability map, that could be anything. It could be low contrast, segmentation error, or other artifacts.
So you look at the B scan, Don, is what you're saying.
Absolutely. If I would not call nasal damage without clear indication on the B scan. Absolutely. Okay. Yeah. Do you think OCT metrics of the nerve are helpful for diagnosis? Well, this is somebody who probably wants to give me a slow pitch, given how much we've written on this topic. I am really anti-metrics. I think this is an incredible technology, and to depend only, I'm going to say only, to depend only on global thickness or quadrant thickness is a huge mistake. It'd be like taking an MRI or a CAT scan, finding a tumor, and then using some kind of a computer to tell you if it's getting larger as opposed to looking at it. So the answer is helpful, maybe, but often misleading and dangerous to depend upon. If I had to choose one that I would pay attention to, I think the quadrant one is the best in terms of minimizing false positives and false negatives. But nevertheless, look at the whole report.
So, Don, as it says, I look at the word helpful, and there are a few things on the metrics that I would use. One I had said already, the disc size. I like that particular metrics. I'm not looking at and saying if things are green or yellow or red, but I'm just looking at some of the numbers. Mm-hmm. Two, I like to look, for example, what is the average nerve fiber layer thickness? If we start seeing an asymmetry between the two eyes and the image is look in terms of the signal strength or the quality of the image similar, maybe there is something going on there. So I think just looking at, I agree with you that the mistake people have made is to look at the colors, to only concentrate on them. And I think the one thing that you have shown time and time again is the importance to look at the B scans, to look at the flip it around to the nightstand and look how
right.
colors are. I mean, that's huge, but I still think there is a little something to look at just by looking at some of the metrics.
Yeah, I certainly agree with you about rim size. It's not something I pay attention to, but I appreciate from a clinical point of view why one should. Global thickness, be very, very careful. It's often misleading. For progression, we have like 3 papers now in the last year in progression. Forget it for progression. 5 micron, the rule of 5 microns, you can easily get 5 microns with subtle segmentation errors. So yes, be very careful with global. Okay. Is OCT necessary in cases of advanced glaucoma? The reason I'm hesitating is the word necessary. So in terms of background, it's commonly believed, and you can find lots of articles that say this, that OCT cannot be used for advanced glaucoma. And this speaks to the last question as well. In particular, it's thought that once you hit a base level of about 50 microns or less, you can't use OCT to follow. That is true if you look at the metric. However, it's not true if you look at a good B scan. So what we've demonstrated is if you have any vision left on a 24-2 or a 10-2, that's 8 dBs or better. Any single point, 8 dBs and better, there's a very good chance you'll be able to see the tissue associated with it in the B scan and follow that for progression. We are using it right now to follow about 100 patients with advanced progression and making good use of it, where you're, in some cases, global thicknesses of 30, 25, 40, and so on. Thoughts, guys?
So, I agree that
I think, Don, it's important to have a good B scan.
Yes.
And so,
yes. Well, there's one.
sorry,
Yes.
I think we're talking over one another.
Yeah. No. It's important to have a B scan, a good B scan, and there's one manufacturer that needs to be reminded that they should put that back in their report. Others have it.
So it becomes a whole new sophisticated analysis to be able to monitor using the OCT as glaucoma, gets into the advanced stage. No question that you can do it. I mean, whether you're looking at the inferior, superior quadrants, looking at, visibly looking at the B scans. But it's it's a whole, it's what this is about. This webinar is about is just using the OCT for all of the tools that are there. We don't go much into this webinar in terms of progression, and using it, but yeah, it just requires you got to really know what to look for to be able to.
I don't disagree. I don't disagree that this is flying in the face of common practice. I do disagree that it flies in the face of common sense. So if a retina person was looking at this, and I've talked to lots of retina people in audiences where I give a glaucoma talk, they say, "You mean the glaucoma specialist is not looking at the image?" I mean, they can't believe it. So you've got lots of optometrists and ophthalmologists out there that aren't glaucoma specialists who routinely look at the image. We should be routinely looking at the image. Crazy.
I mean, that's just how historically how the OCT.
Yeah.
Less relying on the color.
Yeah.
Yeah. And it doesn't make it right.
Yeah.
Anyway, this is good. People should hear the interaction. So we have a little time left. I don't see another question at the moment.
Well,
So
we have the question, Don, that we never, there was, why don't you do not use rim area or cup volume for evaluation of glaucoma?
Oh, I missed that one. Yes. Okay, good. Go one. Yeah. So if you're asking me that, because I guess that is for me, because I commented that, is I have no need for it. I have yet to see a situation where I would require that as opposed to the other things I look at. This doesn't mean that it's not useful. It doesn't mean that some people wouldn't find it more useful than some of the other things. So, but I saw.
Well, Don, it really comes back to this whole issue of that we don't use many of the metrics at all from the optic disc. And I've always looked at them that's due to, in part, the way those disc measurements vary the manufacturer to manufacturer, and they're not consistent, as compared to the nerve fiber layer measurement that is a little more consistent. So it's
the variability is probably the key factor with this and other metrics. With that, I think we're pretty much wrapped up the questions and our time here. All right, those are really good questions. So now we switch to section 2 here. And what I'm going to be doing is I'm going to show for each of these 8 examples, the reports from 2 or 3 of the companies. And then our clinical experts are going to make comments and we'll have a discussion. So let's get started. The first one I'm going to take a little bit longer just to review what's in the reports. So what you're going to see is you're going to see this report from Topcon, you're going to see this panel map from Zeiss, and you're going to see this report from Heidelberg. So let me just remind you that how this report is related to what you might be used to. So I think everyone who has used Zeiss at one time or another is familiar with this report. This thickness map here is the same as this thickness map here. And this probability map here is the same, is the same as this probability map here, right? Now, this does not have macular in it. So some of you, I hope, are also looking at the macular report. And so now the way you read this is this probability map here is the same as that there. Now, this report does not have a image. If you want a circumpapillary image, which I really encourage you to look at, you've got to go here and double click on this and you get this image. My preference, that, by the way, that's a derived circle scan. My preference would be to have it here and to do a little spatial averaging so it's a little prettier, which wouldn't be hard to do. But anyway, this is worth looking at. All right, Topcon, I don't know if you're using this older report, this is equivalent to that. And this is equivalent to, the middle of this is equivalent to this. Heidelberg, if you're using this report here, for example, this thickness map would be the same as this over here. And this kind of an image here, you can find in a couple of different reports that Heidelberg has, like this one here, for example, although this is a T-SNP. Anyway, that's the relationship. All right, so now let's go to our experts. Murray, Mike, what do you see here? Let's suppose that this was my patient and you were going to see the patient as a favor from me or whatever, and I sent you these reports. What would you say?
So, Don, this, what I see in this report is what you described as classic glaucoma. If we first start by looking at the Topcon report, I mean, there are a couple of, your first piece is to look at the nerve fiber layer scan and to see if there is any if the segmentation's okay, if there's any loss, and the segmentation looks fine, and it would appear that there is some loss inferiorly right on the scan.
Can you see my cursor, by the way?
Yes, I can. Yeah.
Okay, so
right there. Yep.
right there. Yeah. By the way, that is my eye always goes there first. That is the most common place to find glaucomatous damage.
Right. And now, then, on the TopCon report, it also gives you the on-FOSS image where you can see that nerve fiber layer wedge defect at about 7 to 730, as well as you can see it in the nerve fiber layer thickness, view. So, we can see that there is some loss there. Now, what I would also like to say is that if we go right above there, one of the things that you have on your report that I really love is that you have these red lines that you don't see in the other reports that are that give you the average or typical position of the retinal blood vessels. And there'll be other examples later on where people can understand the value of just going and seeing where the blood vessels are, and they tend to be in the classic points of the peaks of the humps. And what people should be aware of is that when they see the double hump appearance, the conventional wisdom is that the reason you have these hills are because of an increased amount of nerve fiber layer tissue there, ganglion cells, but that's not the only reason. It's also where blood vessels typically are, and that's what we're seeing there, and that there are some situations where the blood vessels are in quite the right position, and you can get some artifacts. So that's just an aside on that. And then when we come and look
before you leave that point, Murray, let me just say, that was a great summary. The other way to think about it is, the major vessels here, vein and artery, are more or less in these positions on average, and also in this particular eye is average because you can see the shadows. And so the thickness here, as you point out, is due to blood vessels, both directly and indirectly. The blood vessels contribute to the thickness, but also the blood in general, the fibers run along the blood vessels. Yeah.
So, the other thing that we see is, you can see both, in the probability maps, just, as you described, that arcuate pattern that's extending from the disc going right into the macular region. When we look at the panel map, we're seeing that similar appearance. But now
by the way, let me show you this. Yeah. This is flipped along. This is in retina view. This is now flipped so that I'm going to do that on most of them. So this is now field view. So now you can directly compare these.
Right. And you can get an idea just of where you would expect, both on the 24-2 and the 10-2, the points on the visual field to be flagged. And then when we come down to the Heidelberg hood report, you get another appearance. Now, the first thing is that you can see in just looking at the B scan that, again, that little wedge defect, that bite that's been taken out of the nerve fiber layer right there, and it really pops up. And there is a value for looking at the B scans, as you pointed out. Can see under their in this case, what we really never talked about, and that you alluded to almost stay away from, is the summary data for the OCT. Well, you alluded to it for the visual field, but you can see the summary data, both the quadrants and the clock hours that are apparent both on the TopCon and the Heidelberg. And the point that I would like to raise there is that while in these cases those areas are being flagged, the clinician needs to be careful in assessing those, because of averaging of an area, deep, small defects may not show up there.
Well, this
So-
this is a great example of that, Murray. In fact, you
Yes.
know, I mean, this is BMO. You know, this is not retinal nerve fibrillation. This is retinal nerve fibrillation. It looks perfectly normal.
Right. Yep.
This is the quadrants. This is retinal nerve fibrillation. This, if you just looked at, personally, I don't look at these at all. But admittedly, I'm an extreme. If I were to look at one, this is usually the best one. In this case, it would tell you it's normal. And look at this big defect.
Yeah. Yep. So no, I agree. I mean, I do look at them, but I look at them in the same way that I look at a visual field grayscale, understanding the limitations to see if it gives me an overall gestalt. But just like I said, there are, and as you just pointed out, big limitations.
Okay, so maybe we should move along if that's okay. Yeah, so I just wanted to point out to remind you, this is ganglion cell retinal nerve fiber layer. I want to take this opportunity to make the following point, and Murray sort of started talking about this. If we take this, and now we superimpose this, look at that agreement. If these two plots have topographical agreement, it's almost certainly an optic nerve defect. Artifacts don't do this. So if you see agreement here, you're almost done by right there. Same thing here. If I take this and I combine that, that's, by the way, what this is doing. You know, now we have a direct comparison to this. All right, patient number 2. The only thing I want to start with is, let me blow these up. So I just flip this one along the horizontal, and I have a blow up of this and a blow up of that, just so you can compare the three. So what do you see, guys?
So Don, you know, I think I would continue to emphasize some of the rules that you made, you know, looking for the characteristic arcuate pattern, but also looking for the agreement within the plots. And I think another important point for the clinicians is that on a lot of the probability plots, you may see this abnormality sort of jump out at you on the page. But I would encourage them to start in a stepwise, methodical process, as you outlined, which is look at the B scan first. You know, even though there's, you know, clear abnormality here on the retinal nerve fiber layer, on the ganglion cell layer, let's start with the B scan. Let's check for segmentation errors. Let's check for areas of abnormality. Let's move down to the end-stin plot and to see where areas of abnormality are and how they correspond to the B scan. Yep. And then what I do is I go across the bottom. I start in the lower left with the ENFAS. And, you know, there's, you know, maybe not clear areas of thin. There's some areas of thinning there, obviously, but it's, you know, maybe more identifiable in other images.
You can almost see what Hoyt used to call a rake-like appearance.
Yeah.
In some cases.
Yep. And then the thickness map may show that as well. And again, sometimes you can see the, you know, dark blue wedge-like defects that we see in glaucoma there. But again, it's just you're building one plot and presentation onto the next. As you guys just mentioned, don't spend too much time on the quadrant and clock hour plots. They're just to the right of that. I continue moving across the right on the bottom of the page and ganglion cell thickness and the retina view. And then I usually quickly go over to the bottom right for the probability map where that's flipped into field view. And then go up to the retinal nerve fiber layer probability map. I see arcuate damage extensively, and then in both hemispheres, and it correlates well with what I'm seeing on the ganglion cell map there. So there's a lot of agreement there. There's a lot of classical patterns, and I don't see a lot of evidence of artifact or other misleading masqueraders, if you will. And I think we see that on the panel map. It's a little bit off alignment, as the panel maps sometimes tend to be. You describe sort of a cookie cutter, matching of these two plots together. There's a little bit of evidence of that. And then you see similar findings on the Heidelberg Hood report down in the lower right.
I want to go back to the cookie cutter in a moment, but
Yep.
I really like your approach of making sure what you're doing is systematic. And I think the beauty of topographical agreement is you can start any place, right? I tend to start here and do this and do that last. But that's not your point. Your point is you want to be systematic about it.
I think when you're learning it, when you're experts, then you can jump around. But,
You took the words out of my mouth. I was about to say that for learning it, you want to be systematic or you're going to miss things.
Yep.
Once you're an expert at this, as my colleague Gusta Morris keeps saying, always tell clinicians they can be faster. Time is money, right? Always tell them they can be faster. So when you're really a pro at this, you say, whoa, look at this. That's almost certainly. Yep,
Right.
yep. I'm done in 5 seconds.
Yep.
Right.
But you gotta practice to get there.
Exactly right. Now, what I was going to ask you, but you've already answered the question, is how come this is nice and clean here, and this has all this schmutzy red stuff here, right? And the reason for that is a cookie cutter effect. That is, this is not simply this probability map. It's this probability map after they ignore everything outside the central 10 degrees or so. So they put a mask on that looks something like this and then remove everything from the outside. Patient 3.
Okay, so I'll start with this. And in this case, it appears the segmentation works and the nerve fiber layer in and of itself looks okay. And I'm not seeing much, much particular loss. It's more of, it may be that the scan's a little, the measurement's a little low on, perhaps on the superior side, but, I'm seeing more noise than anything else. And I'm seeing a similar type of pattern if I look on the paddle maps for the serous. Exactly, yeah, right there, some noise. So I'm not, so this to me is, it doesn't look like there's much there in my view.
Yeah. So unless you had other evidence, you're going to do, you guys, from a clinical point of view, you're always going to do your clinical exam too, right? So if the clinical exam looked okay and you had this, do you get a visual field even?
Depends on the other risk factors.
Yeah.
Okay.
So what's interesting about looking at OCT reports first, and I'd like to hear Mike's impression, being in education, for students and recent graduates. Maybe they're starting to go with the OCT as the first clinical view. To me, being far older, the first thing that I'm used to looking at is the photograph, or what the back of the eye looks like, whether it's a nerve, the nerve fiber layer, and the macula. And the OCT is done and assessed based upon what I originally thought. So it's a little different. So the first thing I would say is, what did I see with my view? What is my first assessment? Does the OCT reinforce that or not?
Here's the photo on this person.
Yeah. And I don't see much there at all.
It's pretty good, right?
Yeah. So exactly. So
now, if you were going to do a visual field on this person, what would you do? 10-2 or 24-2?
Well, in this case, I'd probably get a 10-2.
Yeah.
Just 'cause it looks like there's more points flagged in the macular region.
So one of the things that Gusta Morris does clinically, and that we have both been teaching for some time now, is it makes a lot of sense to get an OCT if the workflow allows it before you do a visual field, and then choose your visual field based on the OCT.
Yes, I do that a lot in my clinical patient flow, helping to best choose whether or not I need a central field or I can stay with a traditional 24-2 grid pattern.
But as you know, many clinicians just say, I'm going to get a 24-2 because that's what I've been doing for years. And
I'm trying to limit, in some cases, the number of tests that
technically now, we should probably tell the audience that we're in the middle of the pandemic, COVID-19 at the moment. If we were in person, we'd all have our masks on.
Yeah. I just take a minute to go back to Murray's question about, OCTs versus clinical examination of the optic disc with students here. And it is, both of them are so important. There is sort of a natural gravitation to spend a lot more time on the OCTs, but I continue to emphasize that, you have to look at the patient. You have to have a good, clear photograph, or you have to do, some form of indirect ophthalmoscopy. And now those skills, the ophthalmoscopy skills will bail you out of the difficult OCTs to interpret.
Right. Okay. In this particular case, this is an example where the cookie cutter, especially if you just had one hemifield, you might get confused and think that's an arcuate.
Yep.
Whereas you wouldn't be confused with this. This is just sort of diffuse. As Murray said, that could be segmentation, or it's more likely that somebody's got to be in the lower 5% of normal, right? So This person could just be relatively thin ganglion cell layers.
So Don, when you see only this type of loss on the ganglion cells plots and not really on the RNFL, likelihood of glaucoma, there's often a question of, can I have glaucoma only in the macular region first? And does it come first? And those type of questions.
So the answer is absolutely yes, more common than you think. But before I'm going to say macular only, I want to see two of the following three. I want to see this down here, and I want to see this at least in the yellow.
Okay.
If this is like this, and this is down the yellow, that's a suspect, and I want a 10-2.
Gotcha. So you're saying there is some agreement then, meaning the RNFL, the circumpapillary RNFL, is thinned a little bit, versus no agreement and only macular damage, which may be some other artifact that I'm sure we'll talk about in a little bit.
Right.
Great.
Right. All right. So what's going on here? Let me blow this up here, and let me blow this up here. Is it ringworm? What? By the way, I heard a talk about a month or so ago where the expert claimed that this was, if you saw this, it was MS.
Wow.
Yeah, this was.
Well, what we have here is, this abnormality on the ganglion cell probability plot that's very evident to us. When I look at the B scan, and the end-stin curve, I don't really see anything. Maybe a little bit in the nasal area, it's dipping down into the yellow, but.
Oh, that's way outside of this.
That's way outside, exactly. So that's not anything.
I guess you could fantasize that or something, but not really. I mean, yeah, that's a good question. So if this were real, right, then we really should see this down in this region here, right? I mean,
right. So a little bit, and this is just too normal. So it's looking to me more like, and this is, not sort of an anatomical, pattern that we see, or a pathological pattern that we see in glaucoma. It's likely to be some type of artifact.
Yes.
The shape of the macula is, could be.
Yes. That let me skip this and we can come back to this. But let me do this. Here's a paper we wrote a couple of years ago. This is a very common artifact, and it has to do with the fact that we have different shaped foveas. So some of us might be like this, some of us might be shallow, right? And you're comparing to norms. So this is very common. If you've got a ring within plus or minus 4 degrees or so, it's almost certainly a normal variation. Now you can be potentially fooled in some cases. And if you see some kind of evidence like you were talking about, Mike, you certainly want to do a 10-2. But this is not atypical. This is quite common. It's a common artifact. And so for example, if you do a B scan through this region here, right, then you can see that nothing looks unusual. It's just that, again, somebody's got to be at the lower end of normal, and this does not have a particularly deep foveum, this eye.
Welcome back, everybody. So I'll be moderating this 10-minute question answer session. And thank you for all your questions. And feel free, please type in, put in any more questions that you have. We're going to try to get to every one. So first question, and this really goes to Dr. Hood. What could be the evolution of the Hood report in order to be more specific about early glaucoma? What could we expect in the future?
Yeah, so let's just talk about diagnosis. We'll save the issue of progression for a later question. At the moment, I should say that most of the data that were used to validate this report and most of what we published actually was early glaucoma. So I'd like to think this is pretty powerful for early glaucoma. However, we're going to see in the future, and even now to some extent, reports that are more interactive and that will take you to the screen. So for example, there's a dashboard now that TopCon has that's based on our report that you can click on a thickness map and see the individual B scans. So you can quickly find out what's happening to the scan through the fovea, for example. More long-term, we have a recent article in Journal of Glaucoma in which we talk about how you could combine it with models to actually see where the arcuates are, so you could put a cursor on the retinal nerve fiber layer thickness map around the disc or the scan around the disc, and then up would come an arcuate in the other maps so that you could see the relationship between the two. So I think you're going to see more interactive and more information in B scans, and also the ability for the report to teach you what you should be looking for.
And hopefully in the future, Don, there'll be some artificial intelligence neural network built in.
No question about that. Yeah, we are among others. We've got a couple of articles on this. There are all kinds of articles out there. They're not ready yet for prime time, but they're getting better and better. Absolutely.
Right. Yeah. MRW, minimal rim width, or retinal nerve fiber layer thickness, which one is more effective for glaucoma diagnosis? Mike, you want to just start with that?
Sure, Murray. I think if we look at the literature, there are a number of supporting articles, certainly more for RNFL. That's been, the longer term parameter and metric that we've been following for glaucoma. And MRW, minimum rim width, is a more recent metric that has been evaluated. I think, again, the literature is a little bit split on it, and there's some supporting evidence for both. Clinically, more people probably rely on the RNFL, and there may be some edge there in certain patients, and certainly more comfortable with that clinically. Don, do you have any thoughts on that?
No, I mean, I agree with everything you just said. I would also add that it's going to depend upon what you're used to. There are people who are minimum rim width believers who have spent a lot of time on this, and they've gotten pretty good at it. I think it's going to be a lot easier to teach retinal nerve fiber layer. The B scan is all you really need if you want to visualize something and not depend simply on metrics, which we've already discussed are flawed. Whereas the minimum rim width, you're going to have to look at successive radial scans. And there are reports that do that too, of course, but yeah.
And I guess I should say, when I'm using minimum rim width, I am also using the RNFL.
Yes.
And so I'm looking for, right? And this goes back to our discussion in the previous section, which is, optic nerve head specific parameters, which I think we would put MRW in. And I'm looking for correlation there. When I have good correlation between the RNFL segment that's abnormal and the same MRW segment, if you will, the topographical correlation there, then I'm more confident. And of course, there are unusual or outlying glaucoma cases where sometimes the MRW shows me something that the RNFL does not.
Yes. So I just hit an interesting point. One of the original arguments for it is the minimum rim width is much closer to what you're used to in rim width, and it's closer to the disc. Wouldn't you want something closer to the disc? And the answer is no. What it misses, and we've had examples already in this session, are these arcuates close to fixation, because that arcuate starts out wide And as it gets closer to the disc, it gets smaller and smaller. I can't do this on the screen, obviously. So by the time it gets to the disc, it's disappeared into the noise.
Yeah. Okay. That was great. If I could just one last point. So minimal rim width is just the way that the Heidelberg, and it turns out Cirrus created to figure out the rim thickness. And we talked about the problems with the variability, that they went from the basement membrane opening and then the least distance to the surface. And they drew that or looked at that rim all the way around. So it created some consistency. I mean, I agree, with everybody else. I still rely on the RNFL, though, I think the MRW is often useful. Do you use en face OCT images for typical cases?
I think there's a lot of help there.
Yeah. So it takes 2 seconds to look at it, So if you mean, how often do I need it? I don't need it very often, but when I do need it, it's very valuable, because especially defects up near 12 o'clock, which can be very narrow and not show up very well on a probability map, they'll show up very well on the on-flash.
Are you looking for an RNFL slit defect is what you're saying? Or
yeah, exactly right. If
you're looking for RNFL defects is the reason you would use the en face.
Yeah, that's right.
And times that there.
Well, also I'll add one other thing, Murray. It is dynamite for looking at ERMs. It is the best way to spot ERMs. You can spot ERMs on that you can't see on a fundus photo.
Because you're seeing the waviness or the glistening of the
because you're averaging right below the inner limiting membrane, and that's what's being disrupted.
How do you look at the hood report layout effectively on a longitudinal basis? How much noise variability should we expect over time?
So now we're talking about progression. This is something we're working on. In fact, we just recently published a journal glaucoma perspective on this topic. And the traditional view that comes out of the visual field data is that you need 5 tests or 4 tests to diagnose progression. That is not true with the OCT. In many cases, you can see it between 2 sessions. And I recommend that article as sort of a description of how, but once again, you're making use of the topographical agreement within it. So if you see a change on the probability map, and you also see a change on the retinal nerve fiber layer map, and you see a change on the B scan, you've got progression. So structure agreement is powerful. And you can often, if they're aligned properly, you can flicker between the 2 of them, the way the old timers used to flicker between photos to see progression. So the answer is you're going to see reports getting better and better on this progression analysis. And again, I think the dashboard that Topcon just came out with has the ability. In fact, I know it has the ability to flicker.
And hopefully Topcon can provide to attendees either on the website or somehow a list of, in particular, your papers that have covered these different areas, because that would
the questions we're getting. You mean, yeah.
Should we disregard horizontal or straight line defects on the probability maps? I think when I hear about a horizontal or straight line defect, it sounds like often a blink. That's the first thing I think about, and I'm not comfortable. I don't disregard it. That tells me I look and see where it is, how it cut across the B scan, for example, and realize that that's an artifact, and that's often an image you can't use. And even though it looks like it's abnormal, realize that there's often missing data. Gentlemen, anything else to add on that?
No, I think that's good. It's almost always an artifact. And again, with these reports, you want topographical agreement, and you are not going to see topographical agreement with an artifact. Well, you will, but it won't be in both ganglion cells and retinal nerve fiber layer necessarily.
Right.
It's almost always
repeat the scan.
Yep. Good point. So last question, and then we're going to turn it back over. Are you treating based on OCT findings and fields are consistently not reliable?
Well, that's for you too.
Yeah. Mike?
Yeah, of course. I prefer to have both, as we've been stressing in our seminar today, to have fields and OCT, but there's certainly a number of patients where I don't have visual fields. If the OCT is reliable, accurate, not an artifact, and I confirm it to the rest of the patient scenario, I don't treat based only on OCT, but I can use it to guide me with great detail in many glaucoma patients.
Yeah, I mean, it's not the optimal way you want to manage glaucoma, but there are situations where fields or patients are not giving reliable results, and those are the situations where you got to go to Plan B, and that's concentrate on OCT. So with that, we are just finishing up this discussion session, and let me turn it back over to see the next section.
Okay, well, I think those are really good questions. And I just want to actually, I forgot to remind the audience of something I've been reminding undergraduates for 50 years. And that is, the best questions are stupid questions. That is, these are the questions you're embarrassed to ask because you think, oh, it's such a stupid question. And it turns out everyone else has the same question, right? And they'll just thank you. So keep that in mind in case you've been suppressing a question because you thought it was a stupid question. All right. Patient number 5. Oh, this is a goodie. Let's start with the Zeiss report. Suppose, again, you haven't seen this patient yet, but you've seen this report. What do you think, guys?
Well, it would look like there's something going on superior to the optic disc. There's, an area, actually to the disc. So right above it, it's just shallow.
Oh, you mean this right here?
Right there and right there, yeah. And right up at 12 o'clock, it looks really thin, right through there.
But there's not much here, though.
No, not much there. And if you look at the, and then at the thickness map, yeah, so right there up to, so on the Tisnet, it looks like the superior that it's reduced. So, it's an unusual appearance of what would appear to be some loss superiorly.
Okay, so now let's add this report. Some weird looking things here.
Yeah, you can see, irregularity, if you will, on the en-face image. So I'll start down there, and then the RNFL thickness map to that just doesn't follow the normal pattern that we see. So it's not like glaucoma. It's not like normal. I have to start thinking of other conditions that may be contributing to this. I have to go back up, of course, and look at the B scan and see what type of irregularity is in there. And, it looks like the segmentation is okay. I don't see thinning per se, but it's very irregular, I guess, is the term I would use.
Maybe something here, right?
Yeah.
Right. So here's the Heidelberg, which shows abnormally thick.
Yeah.
So before I let you finish, let me make a point here. Whenever you see strange looking patterns like this or like this, you want to suspect an epiretinal membrane, right? It almost screams epiretinal membrane. Now, it just so happens that the en face is probably the best way to pick up an epiretinal membrane.
Yep.
I mean, we can go into the details, but essentially what we're doing with the en face is averaging the thickness right below the inner limiting membrane. So wherever there's a break in the inner limiting membrane, like the epiretinal membrane can do, then you're going to get dark places. And you can actually even see the stretch marks. It's easier to see epiretinal membranes on this plot than it is on a fundus photo. So all right. So this stuff here, and this stuff here, and this stuff here, and this stuff here, and this extra thing here. See this? That's all this. That's all epiretinal membrane, right? And if we looked at individual B scans, and I'll show you one in a moment, you can actually see why it has these patterns. But as a clinician, so this eye has epiretinal membranes, but does it have glaucoma too?
I can't say that the patient has glaucoma based on these scans. At least I don't think I can. And so
all right, how about I'll give you this too then?
There you go. And so again, I don't see much evidence of glaucoma there. I would look at other risk factors, and I may not proceed with other visual field testing in this case because I think my risk of glaucoma disease appears to be low, but that's my opinion.
Oh, okay. So you mean you might refer him to a patient to something else?
Well, yeah, if it's a retinal problem and I'm looking, say again, I presume glaucoma suspect, maybe scans were ordered. I don't know that I need a full workup for glaucoma based on this OCT information is what I'm suggesting.
By the way, I'm told by some of the experts, I'm not really good with photos. I've learned something from all you folks over the years, but I'm told that the fact that these are straight and not wiggly often is a sign of epiretinal membrane. However, I'll maintain that that's subtle compared to what the ENFAS can do. Murray, did you have anything else you want to say about this?
No, I mean, I think Mike said it. I mean, I like to look at the macular images. That's why I like a wider angle photograph
Right.
that we can get just to get everything in too. And you can see the epiretinal membrane.
Right. Better. Right. So here's 3 years of fields.
And
I mean, you've got this that's consistent, but then, it's chronological this way.
I'm not seeing much of a pattern there that's consistent with glaucoma disease.
Right. Those fields are all over the place. I mean,
Yep.
a lot of variability.
Here's the 10-2.
Yep. Again, if this patient had elevated intraocular pressure, then there's a greater concern. If this patient, and again, of course, we know patients can have glaucoma with normal pressure, but with normal pressure and minimal other risk factors, I don't think that there's a high risk of glaucoma here just from the evidence that I'm seeing. And I certainly can't make a diagnosis from this. At least I don't think I can.
So if we look at the B scans through this, we can see what's going on. So let's take the 10-2.
Mm-hmm.
It's hard to know whether to believe this or to believe this, right?
Yeah.
Take a look at the B scan. First of all, you can see how the epiretinal membrane messes up the algorithm. All algorithms are going to have trouble with the epiretinal membrane.
Yep.
But you look at this here, and you can see the breaks in the retinal nerve fiber layer. It is acting as if all of this is retinal nerve fiber layer. I think the retinal nerve fiber layer comes up like this, right? And this is largely ganglion cells.
Yeah.
And you've got pieces of the retinal nerve fiber layer missing.
Yeah. I mean, the first thing is it's a segmentation algorithm failure.
Right. But the second is when you look closely at this image, there are pieces of retinal nerve fiber layer that have been removed by the epiretinal membrane. I mean, look at the damage here. So this was actually a patient that was sent to us for advice. And my answer to, does this eye have glaucoma, is I would say not. I said exactly to the specialist what you said. I would not call this glaucoma based on the OCT. In addition, there's enough epiretinal membrane damage to the nerve fiber layer to account for some of these fields.
Yes.
Yep.
It's interesting, yeah?
Yep.
Yeah. So, sometimes you can get by with the nerve fiber layer, the circumpapular scan, if the epiretinal membrane does not extend too far out.
And that was true in this case.
Yeah.
That was true in this case.
Yeah. So
I know I'm reaching, but I'm tempted to actually think that this hypodense region actually is real too. I think that epiretinal membrane is doing a lot of damage.
Yeah.
I want to point out too for the audience that what allowed both of you not to be fooled by this and call it glaucoma is you were looking for a pattern that was consistent with glaucoma, and nothing here looked to you to be consistent with glaucoma, right?
Right. Just because there's some abnormality on the probability plots doesn't mean it's glaucoma.
Right. Okay, patient number 6. Is this normal or is this glaucoma?
I'll start this again. If we look at the B scan, it the B scan looks, especially on the inferior side, that there may be a little thin, maybe on the B scan, but that's not clear. When we can see on the paddle map at 6 o'clock, there's an area of defect, and even there's an area of defect at about 1 o'clock. So I mean, there are areas of that are flagged. The question, the question is this glaucoma or something else?
Something else being what in this case?
Well, I mean, high myopia.
Yeah. So where are the blood vessels?
Yeah. Tilted disc, something like that. So it looks like, well, let's see. So the blood vessels, that blood vessel lines up okay.
Well, so here's where this should be the center of these.
Right.
This is a little bit over to the right, and so is this peak.
Yeah. So the peak is decentered, so it could be related to the blood vessel right there.
Right.
Off a little bit.
The other thing I noticed too, that this is nice and smooth. You don't see the vessels sticking up.
Yeah.
Which you would tend to, even if this guy started out thinner, I think, but they're the shadows
for the blood vessels.
So for the blood vessels, it's close, but not, it's a little bit shifted because that's where it should be. So in any case, again, let's suppose there was other reasons to suspect this patient. You'd get a visual field. What field would you get?
I think I would go with 24-2 on this one. I'm not sure I see so much central loss. I see more on the RNFL probability.
Yeah, so this right here, which we're worried about, right? Or is this right here, right?
Yeah.
So basically, we're looking for an arcuate that looks something like this, right?
Yep.
Yes.
Right? So that's a 24-2. So there's the 24-2.
Yeah.
Let's blow it up. That's where the arcuates are. There's no evidence.
Yep.
This is a normal control.
Yeah.
But yeah, that pattern is really tricky because there is sort of an arcuate shape to the pattern, both superior temporally, inferior temporally, and without taking a closer look, it could be misread and misinterpreted.
Yeah, it is probably the most common misinterpretation.
And again, Don, this was from the blood vessel location primarily, you think?
This is primarily blood vessel location, yeah.
Yep.
And again, the thickness, the plot, blood loss, simple answer, blood vessel. You can see it here too. See this right here?
Yeah.
It's lined up there,
Yeah, inferiorly it lines up right there where you just were. It looks like it's off a little more. But, it just brings up, the point to clinicians that just because there is some areas flagged on an OCT report doesn't mean it's due to disease, that there's a lot of variability that can occur even in normal individuals.
Yeah. So what essentially what we're seeing is red, and that red is saying it's abnormal compared to normals, but it doesn't mean it's a defect or disease. This is an anatomical explanation. So this is a suspect with glaucoma. You wouldn't change your mind based on that, presumably.
No.
Or that.
Yeah.
Okay. What's going on here? So what's going on where the red arrow is, and what's going on with the black arrow? I only have a report from TopCon for this eye.
Well, for the red arrow, we're pointing to nasal region, superior nasal to the disc, and on the B scan, it looks like there's segmentation failure.
So yeah.
So I actually have this reversed. I think of it, but so what you're saying is this is associated. Oh no, I'm sorry. No, I have it right. This is associated with this. Yes.
Correct.
Right.
And to me, I mean, that's just.
I think I had that picture. Yeah, that's what you want.
Yep.
Yes.
When that drops all the way to the bottom, then generally that's some type of segmentation failure, because there should always be a little bit of residual.
That is a great point. That is a great point that I try to remember. Anytime you see this going to zero, check the segmentation.
Well, it's an artifact, right?
Yeah.
But so, what catches my attention is when right in the top left, when you look at the B scan, there's a certain curvature of the B scan where it barely fits in that box.
Yep.
And all the other reports you've showed up until now, it's been, the B scan has been relatively flat with the peaks coming up. When it barely fits it, yeah, that tells me, that looks like somebody who is highly myopic is the first thing I think about. May even be a type of tilted nerve going on.
It's a high myope. You nailed it. It's a high myope. Yep. Yeah, so this shows you what can happen with high myopia in terms of how far off you can be with where the peaks are.
I think, Don, someone from the audience might still ask about that infratemporal defect. I'm sorry, it's supratemporal because I'm looking at the field view. But on the field view for the RNFL, yes, that may still cause them to go, well, maybe there's still glaucoma there. How do you talk to that?
Yeah, and that's the same point we made with the previous eye. That if you look at this is super normal.
Yeah.
This is super normal, not because this person has more retinal nerve fiber layer, but he has what you might have over here, all pushed all the way over there.
Yeah.
So this is a dead giveaway. You might say epiretinal membrane? No.
Right.
Segmentation error? No. It's all the tissue is here because this is a high myope, and he developed with these vessels much closer to fixation.
Good example.
Yeah. What about this red dot? Do I worry about that?
Yeah, I'm trying
that again is well, I would always look at the macula in the view, but that's just a segmentation problem would be my view. And with with a myopic eye, especially highly myopic, you're dealing with these segmentation failures or unusual. So I would not, that there doesn't appear to be anything going on that I can see.
Yeah. So the point, we routinely look at a B scan through the fovea, routinely, because you pick up all kinds of incidental findings, right? And in this case, you would you see a normal fovea and normal segmentation. And here's the problem. This is not uncommon. The problem is you can only center the scan in one place. So if you center the scan on the disc, then there'll be variations in distal fovea distance.
Oh,
right.
Right.
So this person's fovea is a little bit to one side of where normal is, if you can picture it.
Yep.
So if we looked at significantly thicker, you may well see a significantly thicker place next to it.
Yep.
Yeah. But again, Murray's point is a great one. It's not a bad idea to look at the B scan through the fovea on everybody. And in this particular case, any concern you had would be dismissed. But anyway, red dots here. There are ways to get rid of this, by the way. There are some fancy ways of centering this part separately and then fuzzing the borders that we've been working on. But for now, you don't worry about a red dot in the center here. And this here, this is what we were talking about. This is basically this mic, right? And it's because all the tissue has been pushed over.
Right. Blood vessel.
Okay, number 8. So let me start this one. We have a blood vessel location problem again. Look at this here, right? This is the opposite. This wasn't a hyperope, but you'll see it in hyperopes. You've got this over here, and that's where the vessel should be. And so that could be vessels. You've got this over here, and that's where it should be. So the blood vessels are going to be contributing to these abnormal regions, but
Yeah,
Is,
but
is the glaucoma too?
yeah, as I continue to look, again, starting on FOS and then RNFL thickness, and then more importantly, the two probability plots for the ganglion cell and the RNFL, there's clearly arcuate damage more inferiorly here, and but also superiorly.
Retina-wise, right?
Retina-wise, correct.
Yeah. Right. And again, applying applying that rule I mentioned earlier, this is
goes
the
right
same.
into that.
It goes right into that. Boy, so maybe artifact blood vessel, at least in part, maybe artifact, but this gets nailed here. And this comes up to there, gets nailed there too. So you've got arcuate defect there.
Yes, and that's relatively consistent with what the Pano map and the Heidelberg report shows. Again, each of them will vary a little bit.
Yeah, you can see the similarity in general, right? I mean, did I flip this? Oh, I didn't flip that one. Okay.
Yeah, no, yeah, you got to do the flipping in your head for that. But right, that's what we're saying. The inferior retinal damage is greater there, and that should match up with field.
Yeah. So this, this here is this and this here.
Yeah. So even when you shift the blood vessel, you can see, as Mike said, the arcuate loss.
Right.
Yep.
Right. So this is a patient with glaucoma, and the blood vessel location just complicates the interpretation. That's the image.
Clearly glaucoma damage.
Right.
Yeah, you see that superior.
And here are the fields. So let's use this as an opportunity to make the topographical comparison to the fields. So here's the 10-2, here's the 24-2. I don't know how many clinicians have actually bothered to think about the relationship between these two topographically, but just to illustrate that, if we take this and scale it, here, that's it. This scaled properly is this. So there's, so this one point here, basically, you can now see everything connected with it.
Yeah.
So we put these points on the report for a purpose. You can circle that point there or have a resident do it. And that's this point right here. So you can see the agreement. We can circle these points here, and that would be down here. And again, you can see the agreement. If we take the 10-2, this looks sort of funny, but it's not funny at all. If you circle that, you can see the nice agreement with the 10-2. And there, same thing, nice agreement. This one's interesting. This is falling outside the macula, so it doesn't show up well on the retinal ganglion cell, but it shows up beautifully right here on the retinal nerve fiber. Yeah. So again, you don't care about the mean deviation, glaucoma hemifield test, but you do clear, let's put it this way. If I told you that this agree with the visual field and you made a decision versus I showed you this topographical comparison, which allows you to sleep better at night.
Yeah, seeing the topographical.
Yeah. All right, so it's that time again. Let's turn to the chat and see what we have in terms of questions.
Great. So that finished our second section where we took a look at a number of short cases and saw some really excellent examples of artifacts and key things to look for when we are doing our interpretation of OCT reports. Our third section is coming up in a little bit where Murray and I will present more in-depth clinical cases and ask Don to comment on our findings there. We have 10 minutes for questions here in this section, so a number of questions are coming in. You can continue to type your questions into the chat and we will do our best to get to all of them. So Murray and Don, our first question here goes back to the use of perimetry and visual fields. Specifically, the question is asking about using the 30-2 pattern or the CETA swap, that's the blue-yellow testing pattern. Is it useful in making a diagnosis of glaucoma, and how would you use them in conjunction with the Hood report?
Well,
Murray?
if I can just start off just about the whole concept of the, so I assume the person is asking specific about the 30-2.
Right.
And which I have not used in probably 25 years. And the reason is that you have that additional points on the edge that are not useful clinically, but are the ones that get picked off by the trial lens or the lid. And, there's almost no clinical information that you glean out of that. So the 24-2 goes out to 30 degrees nasally, and the additional minute to 2 minutes it takes are just, there's no worthwhile use to the 30-2 compared to the 24-2. And we'll get to the 10-2, I believe, in a moment. The other issue is CETA swap. And CETA swap was a great idea, again, almost 30 years ago, 25 years ago, that turned out to just not bear fruit. And I just don't think CETA swap is all that viable a test in regards to detecting early parametric loss.
So the only thing I would add in response to the second part of that question is how would you use them with the Hood report? The answer is the 30-2, as Murray pointed out, has all the points for the 25-2 plus the extra. So you would use it the same way you would use a 24-2. You would look at the points that are abnormal.
Great. So our next question is probably too long a question to really fully answer here, but it's an important question. Can you discuss the difference of OCT findings with glaucoma versus other optic nerve findings like ION, ischemic optic neuropathy, MS, and a whole host of other things? Don, I know you do a lot of that.
Yeah, so I don't have to tell the clinicians in the audience that in most cases, to distinguish among MS, glaucoma, and ION, for example, or superior segmental hyperplasia, which is another one that's often misdiagnosed, you need a good fundus exam and/or photo. That's going to be helpful. Having said that, you can distinguish superior segmental optic hyperplasia and ION on the OCT if in the following way. If the superior part of your disc is essentially flat, you've lost a lot of tissue, and the inferior part is normal, that is not the typical pattern with glaucoma. Even when you have hemifield damage in glaucoma, the other hemifield is affected. So we've been able to pick up and say to the glaucoma specialists on a number of occasions, please go back and check for ION and superior segmental optic hyperplasia. But the ultimate litmus test is the exam and the photo, right?
So Donna, what about
history? Yeah.
What about the case of AION that, glaucoma, we think about the damage being limited to the retinal nerve fiber layer, as compared to others that you have, most of the layers involved. Is that worthwhile at all?
Well, so in most cases of ION, for example, it is the retinal nerve fiber layer that's affected. But one thing we've been made use of is we tried using minimum rim width.
Yeah.
Under the logic that that's going to be less affected in ION than glaucoma because you've got glial tissue that's remaining. And it does, you can actually take a ratio there, and it turns out to be better than other predictors. But still, you're not going to beat a good clinician who looks at the photo carefully.
Right, who sees the pallor.
Yeah, exactly.
Yeah, I think, putting all of the information together, including visual fields, are some of the key findings there, and the history and everything else, right?
Oh, that's an excellent point. So the ION, you tend to have more damage close to the disc in the ION than you do in glaucoma. That is because of the pattern of loss. You don't see much of the. But none of these are absolute. You're still better off with the photo.
Right. You see, that's why fields. You see the altitudinal field defect where
Same
it goes
thing with,
all the way along.
Right.
So you have one half taken out totally and the other half not even affected, which is, even in glaucoma, as you mentioned, isn't that asymmetric.
So Don, what types of cases or patients are the most difficult to diagnose with the Hood report?
Yeah, that's easy because I've been agonizing a lot about this recently, and it has to do with damage that's mainly in the temporal region of the disc. So you're taught about the isn't it rule. You're taught about the temporal not coming before the superior and inferior. There are some patients where glaucoma starts or is most noticeable in the temporal disc, and those patients are going to be very hard to distinguish from artifacts because foveal disc distance can also create things like that. And they can also be hard to distinguish from other retinal problems. So what I tell people is when I see a big red circle, which could be an artifact, and the region in the temporal down, I also want to see something on the retinal nerve fiber layer that matches. I want it to be in the temporal region, the yellow or red. I want at least two of those. And even then, I want a 10-2 to confirm it.
Great.
So macular damage, and of course a line scan through the fovea helps too. But that's by far the hardest for me, at least.
Next question is on.
By the way, let me just add one more thing for the clinician, actually,
Sure.
if you don't mind. I think these patients are overlooked. I think, and we have demonstrated this now with work with Dana Blumberg and others at Columbia. These are the patients that often come in with these vague complaints. Oh, I have trouble with glare. I have trouble with bright lights. I have trouble with contrast. Take a close look at the temporal region of the macula, because that's often what's going on. There's diffuse damage there that isn't necessarily easy to pick up with traditional tests.
But again, your report allows us to do all of that.
Right.
I would, I think that's part of the.
Yeah.
Go ahead, Murray.
Yeah, and the other takeaway point, and you get into this, Don, multiple times, is that you need to combine the macular scan with the nerve fiber layer optic nerve scan, and you can't, you have to use, just like we have to use fields and all the other photos and other things. You need to use all the pieces, and in some cases, they become more valuable.
Yeah, and you add a 10-2, and you look at the total deviation plot, not the pattern deviation plot, because often if you've got diffuse damage, that's going to be removed by the pattern deviation.
Yeah.
Right.
So that's the most difficult case, at least for me. Good question.
The next question is about, again, artifacts that we see quite frequently, which are discs, large areas of guidelines for OCT interpretation with those two conditions. Any other helpful suggestions?
Well, let me do the first part and I'll let you do the second part. The PPA, you can spot that on the circumpapillary thickness plot in the image. And usually there's something there to analyze, but if there isn't, you still have the ganglion cell that usually is maps that can be used because they're not affected by the PPA.
Right, so macular scan.
Yeah. Tilted discs, again, as long as you're looking at all aspects of the report, that's not a unique problem, although I defer to you guys because you spot the tilt the disc right from the start.
Well, again, go ahead, Murray.
I think, the Spectralis went with 3 different ring sizes, and one of the, and their idea was perhaps when you'd be able to detect progression earlier if you have larger sizes to see the change occurring sooner. I don't think anybody ever has validated that or shown that, but one of the advantages that I have found is that in that larger ring size, in the few cases that does have extensive PPA, the parapapillary atrophy, I've never seen a case of parapapillary atrophy that extended so far out that you couldn't get it with that ring. So, that's, and often you hear about the companies, allowing you the option to change the ring size, but it's just not viable. So that's the only device or the one thing that comes into there.
Yeah, and I agree, but it isn't that often. And don't forget, you still have
Yeah.
your thickness map, which does give you information outside of that, the PPA, so you've got your thickness map of retinal nerve fiber layer and your thickness map of ganglion cells. So,
Right. Right. Use all the tools we have to overcome these artifacts.
yes.
Great. So we are at the end of this Q&A section, and we're going to move on to our third section and talk about some clinical case examples. Thanks.
In this next section, we're going to talk about 3 case examples from the clinic presented by our clinicians. And I think we turn to you, Mike.
Okay, thanks, Don. We're going to go ahead and I'm going to start with this case 1 here. And our goal here is to continue our discussion about OCT interpretations and integrate them into more fully built out case examples of patients with glaucoma. This first patient is a 55-year-old African-American female. She was referred from a local optometrist who was working at a national chain and sent her here to the Illinois Eye Institute. There's no family history of glaucoma. Patient is being treated for hypertension with lisinopril. And at the referring optometrist's office, her Goldmann applanation tonometry was 34 in the right eye and 28 in the left eye at 1:20 in the afternoon. Here's some further clinical data for the patient. 20/20 vision in the right and left eye. External examination was normal. There was no afferent pupillary defect. Slit lamp examination for each eye was unremarkable. Goldmann applanation tonometry at my office was 30 in the right eye and 22, so a little bit lower than what had been measured earlier, also at an afternoon time point. Gonioscopy performed on each eye was open to the ciliary body in all quadrants with light pigmentation. Important risk factors, of course, include pachymetry and corneal hysteresis as a pretty well-established risk factor for glaucoma. And central corneal thickness reading for the right eye was 502 and 497 for the left eye. And for the corneal hysteresis, it was 6.5 for the right eye and 8.0. And really, in all of those cases, those are quite low numbers and thin readings, indicating a higher risk for glaucoma. Since these are clinical cases, and as we were discussing earlier, we like to take a look at the optic disc photos or the fundus photos. Here you can see a wide field photo for the patient's right eye. And, ignoring some of the vascular changes related to hypertension, I think it's important to obviously look at the disc, the neuroretinal rim, the cupping, but also you can see highlighted here, if your screen is clear enough and bright enough, perhaps some early abnormality to the retinal nerve fiber layer, both infratemporally and perhaps a little bit supratemporally. So if you're looking carefully and you have good photographs or ophthalmoscopy, you can see those type of changes. Here's a photograph for the left eye. Smaller cup, looks like a pretty full neuroretinal rim. And again, you might be able to pick up some changes to the retinal nerve fiber layer just based on the flash off the RNFL. Again, there's some minor vascular changes related to her hypertension. So the first scan I'm going to present is just the traditional Zeiss plots and reports for the retinal nerve fiber layer on the left and the ganglion cell on the right. But really, as Don pointed out, we're using the PanoMap reports here as they stitch together the retinal nerve fiber layer and the ganglion cell layer for each eye. And I may need to refer back to the B scan on the earlier reports when I need a little bit more detail. But for these, I can get a pretty quick impression as to where the abnormality is by looking at the probability maps. And here the RNFL is showing this arcuate pattern leading into the ganglion cell area for the right eye. This is a T-SNP curve here, and maybe there's one little blip right there on the T-SNP plot where that's getting into the abnormal zone. And then for the left eye, there's more of an abnormality on the ganglion cell. Again, we should think about all the artifacts that we discussed in the previous section. And I don't see it directly leading back here or connecting up to the RNFL as we discussed a little bit. But that could be consistent with some early glaucoma there. Some of our other testing may highlight that further. Here is the TopCon report, the hood report that we've been looking at. And again, you can just see the same, same plots that we've been talking about in the earlier sections, and go through the building step process here of looking at the B scan, looking for areas of segmentation abnormality perhaps, or areas of thinning on the Enston curves. Certainly an area here, maybe an area here, although this is way nasal and usually not so important. Thickness map down below, and then you have your field views that we've been talking about already. And again, we see good agreement between the RNFL loss and the ganglion cell.
You can also see on the B scan in the inferior temporal region where that's thinned.
Yes, up here, Don?
No, to the left. A little bit. Yep, you passed it. The same place you see it dipping into the red in the inferior temporal, right there.
Yeah. Sorry.
You see the thinning on the B scan.
Yep.
That other part to the right is segmentation error due to low contrast.
Oh, out here, correct. And that accounts for this dark area over here on the probability plot.
Exactly.
Yep. Some abnormality here on the probability plot for the left eye, down here. And again, it seems to correlate with more RNFL loss up here. Do you agree with that?
Yes.
Yeah.
And I can imagine a thinning. It's not quite in the right place, but look at the dip in the just off the center of the temporal region in the Enston curve.
Yeah.
See that? Yeah. See that dip in blue there?
Yep.
If you go straight up, you can see. If you go straight up to the B scan, I'm sorry.
Oh, yes. Here, the thinning.
Yeah. So those are close to being in topographical agreement with what you're seeing. So the answer is yes.
Right. I point this out because it's a little bit different from what we were seeing, from the pano map. I mean, here is a region superior temporally on the pano map. And then on the TopCon, I might look at the thickness map down here. And then on your field view, it's out over here.
Yep.
And these are the Heidelberg reports, showing their typical report. I want to skip ahead, and these are, I just put these in here to show in greater detail how you can take a closer look. This is with the Spectralis instrument, great detail of the retinal nerve fiber layer, and their clock hour report down here.
And you can see that same region. That's now. This is a T-SNP plot. So right where the cursor is. Yep. That's in the same general region that we were just talking about on the top. Yep. Yeah.
Temporal inferior.
You see it there. That's right.
Yeah, and over here on the clock hour report.
Now that's a great illustration of the problem you guys face, not only in detection but also progression. So if you go down to the depression on the Enston right there, that started out life way up, way probably above where that green line is.
Yep.
And it had to work its way through that green before it became abnormal.
Yep. That's great. When can we detect that? And when can we detect that?
If you have images, you can detect it. You can actually detect it from the images and from the T-SNP plot.
Right.
The Enston plot, either way.
Here's the RNFL for the left eye, which looks to be, by the T-SNP.
Well, the corresponding place, remember what we were seaing on the other report.
Superior temporal. Right there.
And go straight up to the B scan. Go straight up to the B scan, right to the left of that where the cursor is. See that? That's it. That's topographically identical to that thin thing.
Visual fields.
I hope people watching this who don't look at images are thinking, oh my God, maybe I should be looking at these images. Right. And I'll say more about that in my brief wrap.
Right. This is a 24-2C pattern, the newer a testing grid pattern from Zeiss on the Humphrey Field Analyzer, where 10 extra points are added centrally, and may have some value in helping to identify early central field defects. Although I still will often still perform a 10-2 because there are just more points here and closer together. And
look how clear it is in the left eye on the 10-2.
Yep.
See, now if you do an OCT first, there aren't going to be too many places where you want to see 24-2. And there may be some, but basically if you do the OCT first, you'll
Right.
decide where do you want to pay attention.
Right.
And it depends on what you're looking at. If you're looking for that macula, then you want this. If you want to try to find if that little thin peripheral defect is real, different story. But
And then what I've tried to do here in these final two slides is to just, put everything together. The photograph, the hood report, 24-2, 10-2, draw the arrows like you do, Don, and, make sure that there's agreement, make sure that there's no artifact, make sure that, I do have a suspect, obviously, with glaucoma. I'm trying to gauge the severity of the disease, develop a treatment plan for the patient, and make sure that I'm not missing something.
yeah, so you as a clinician, you've established with that eye, maybe this eye too, in fact, that you've got damage consistent with glaucoma, and it's impinging on the macula in both eyes.
Yes.
Right?
Yes. And so
So do you follow this patient with OCT and visual fields? And if you do a visual field, do you follow the 10-2 or 24-2? How are you going to follow this patient?
Yes, we'll follow the patient more closely because of macular damage and greater risk to the patient. Probably 10-2 fields every 6 to 8 months, at least at first. I'm still going to maintain some utilization of the 24-2 fields, I think. And maybe there will be a development of abnormality on those over time. So I do want to have some periodic 24-2 fields.
But you do 10-2s also.
Oh yeah, every 6 months or so, 8 months at a time.
So I want to use this as an opportunity because when we first started reporting these findings, there were a lot of skeptics. This is classic. If you look at the 24-2, it's all normal.
Yeah.
It's normal.
Yep.
And not only isn't it not normal, but you've got damage that's already occurred near the macula.
Yep. Right. And this is the patient's better eye per se, right? We know that the right eye, at least by the OCT, again, look at, there is some, there's field loss here, but the OCT suggests, quite a bit of damage. We can see it on the color photograph intratemporally. So that's the right eye. But the left eye is, glaucoma and, sight-threatening, potentially glaucoma as well.
Yeah, interesting case. Great.
Okay. Murray, any comments?
No, I mean, I think you did a great job of that case. I myself early on would get both OCT and fields on a 6-month basis, with the idea of needing to get it about five of the tests. So I probably do, as you said, every 6 months, and by 2 years have at least 5, and that would provide a better metric for progression analysis, which then you start to morph into, and probably would alternate between 10-2 and 24-2. I at least for myself, I'm still more comfortable understanding what the 24-2 looks like over time. But I recognize the value of the 10-2 in particular in this case. So having both will provide some comfort in terms if there is any change where I may be able to see it and monitor the person.
Yeah, may I make just a comment about that? We have a paper that's just came out this month, I think, or it's about to come out in Journal Glaucoma, I think, a perspective that I think it's titled, Did the Eye Progress Since the Last Visit? And it speaks to the GPA analysis and the need for 5. A patient like this, you will be able to tell quite often whether there's progression or not on a good OCT with one follow-up test. You won't need 5 tests the way the GPA analysis. Now, subtle, diffuse damage, subtle damage, it may be a different story, but these local defects like this, you don't need 5 tests if you want to look at the OCT.
Great. All right, Murray, I'm going to pass it over to you for case number 2.
So thank you, Mike, for turning over the program. Let me run now into case 2. And case 2 is a 61-year-old African-American female, and she was told that she might have glaucoma when she was living in Minnesota several years ago. She recently moved to New York and got a referral from her primary care provider for an eye exam. And she does have arthritis and high blood pressure, and the medications for her blood pressure are amlodipine and losartan and hydrochlorothiazide. And she's also using 5 milligrams periodically of prednisone for her arthritis. So let's just look at the next slide. Her visual acuity is excellent, 20/20 in each eye. There's no afferent pupillary defect. The slit lamp is unremarkable. The Goldman tonometry is 26 in the right eye at the first presentation, 25 in the left eye. And gonioscopy was done, and she's wide open to ciliary body in all quadrants. And don't typically do gonioscopy on a first exam. The reason gonioscopy was done in this case is because of the elevated eye pressure, is then the link that would make me want to take a look at the angle structures of the eye. Pachymetry is about average, maybe slightly thicker than average, 552 in the right eye, 562 in the left eye. And the corneal hysteresis is a little low, especially in the right eye, 7.5, 9.0 in the left eye. So let's go on. And this is an optos view of the back of the right eye. And if we can take a look at the left eye, and this is the optos view of the left eye, you can just see the first thing you see is the cup disc ratio is larger. And if we go to the next one, we can see the zoomed image of both the right and left eye. And the disc looks somewhat large. The isn't rule is not obeyed in both eyes, especially inferiorly. There's, in terms of parapapillary atrophy, it looks like there's some parapapillary atrophy temporally, both zone alpha and zone beta where the arrow is. I don't see any hemorrhages there. And in this particular eye, it's kind of hard to see any nerve fiber layer defects. And sometimes that happens where you don't see them on the photographs. And that's the beauty of having the OCT assessment. So if we can go on. And here we're looking at the serous OCTs, both the optic nerve head and nerve fiber layer, and then also the ganglion cell assessment. And what we could see is that there is inferior loss greater on the right than the left, in that the nerve fiber layer in the right eye average RNFL is 79. The left eye is about 85. You can see these wedge defects, both in the right and left eye. And what I also will look at is the B scans, both the horizontal and the vertical of the nerve, as well as the RNFL, and it appears that the segmentation is fine. And I'll take the same look at with the ganglion cell, and can see that there is some loss in both eyes, greater, and it looks like there's a little greater on the right eye than the left eye, also in the macular area. So if we can go on to the next slide, and these are the panel maps, and this is what we've talked about, and Dr. Hood has talked about in terms of integrating the nerve fiber layer, and macular. And you can see in the right eye, inferiorly, that defect extends right up to the posterior pole, the macular region, and that's common. And sometimes the alignment isn't perfect, and that's why you see that break in between. And you may see that, but that doesn't mean that that has to do more with how the image was taken than it is that the area between those two zones is perfectly normal. And you can see the same thing in the left eye of a defect that extends, that's kind of thin, right where the arrow is, right at about 530, and extends all the way out to the past the macular region. So you can get the idea that that there is glaucomatous damage, structural damage in both eyes, with the right eye perhaps a little greater than the left in this view. So if we can look at the next slide now, and here we're looking at the TOPCon OCT, and if we go through the different points that was discussed, the first thing that we see is the B scan, and the B scan, the segmentation worked fine, and it clearly looks like inferiorly the defect is a little thin in the B scan, and you can see it right where the arrow is, and how they correlate. If you sneak a peek down to the en face image, you can see what it looks like at a nerve fiber layer defect in this right eye, right, the arrow is. And then when and the thickness maps are showing that inferiorly the retina is thin. If we then take take a look at the other side and look at the probability map, you can see up above the probability map is similar to the panel map, showing this large defect. That's a probability defect extending from the disc all the way out to the macula. And then you can see how the macula area also has a point being flagged. So, in this case, would think that, there's a good chance that there's field loss, and even field loss within the central 10-2. And if we can look at how the left eye, so here's the left eye, and just the first thing again I will look at is the image quality is excellent, 64. Segmentation appeared to work fine, and perhaps the nerve fiber layer is a little thin, both especially inferiorly. In regards to on the nerve fiber layer thickness plots, right where the arrow, there is a small wedge defect inferiorly, right where that arrow is, that's showing up. And then when we come and look at, think how those will translate to the probability maps, again, for this eye, we see a nerve fiber layer defect extending from the disc all the way out to the macular region. And similar to the right eye, there appears to be some central loss going on in the left eye too. So just based upon the OCTs, a 10-2 is probably going to show some loss, and it's probably some fairly deep loss as well. And there may also probably be loss on the 24-2. So if we can go on to the next slides, and here is we're looking at the Heidelberg case, and it's showing a similar type of view of all the other devices. That if we look right up above in the top left, just at the B scan, you can see how inferiorly that inferior defect, or that so-called hump that we expect to see, is not present, and that there's inferior loss. You can see the Tisnet right where the arrow is missing. When we sneak a peek over at the at the defect, if we look way over to the right, the top right, just in the probabilities, we can again see that defect that extends from the disc all the way out to past the macula. And on the below, we can see in the 10-2, the macular region, how there may be some central points. And if we can just then look at the left eye for the Heidelberg, we're getting a similar type of view, that inferiorly, while we don't see quite as extensive a damage, there is some loss inferiorly. And when we look on the probability maps, again, we're seeing as the field view, so everything has been flipped around, we can see superiorly some loss, And if we go right below that in the macular view, we're seeing again some loss inferiorly. So if we look at the next slide, these are the fields, and we're looking at the fields, and this is the right eye, and we're seeing the 24-2, and there's some inferior loss. So as we would expect, there's some inferior damage. So we're seeing that superior field loss, and for the 10-2 in this case, we're seeing some central loss both up above and down below, and it may be that inferior point and perhaps may just be learning or that may be true defects, that we're seeing damage that is more widespread in the posterior in the macular zone and not as localized to a region as we see in the 24-2.
Can you go back to the TopCon report for that? Yeah, but that was the right eye, right?
Yep.
Yes.
Yeah. So I thought it might be an artifact, but if you look, there it is on the ganglion cell thickness map, right? The lower right hand, the lower right hand corner. That red
right there. Yeah.
Or below. Yep. Below. Move. Put the cursor where it was. There, right there.
Okay.
See, that's not an artifact. That's a little piece of that arcuate that you just picked up in the visual field, right? Isn't that what that is?
Yep.
Yeah.
Yep. We'll put that all together on the last slide.
Yeah, that's okay.
Yeah.
So, and the left eye visual field.
Yeah, in the left eye visual field, so we see the 24-2 showing loss that's extending right into the central region. Now, recognize that this field has, a high number of false positives. So we need to be careful in terms of the assessment. And the same thing with the 10-2, where there are a lot of false positives. So we typically think of when there are that many false positives, the defect is appearing to be better than what it really is. But so, it appears to show some localized change. But again, I would just because of the reliability, I would be careful in how I use these. But in this case, there's, the OCTs are providing a lot of important information in and of itself. So if we can go on to the next, and next slide. Now we're looking at the wrap up. So the wrap up is showing, in this case, you can see the red arrows are showing how the fields correlate to the areas being flagged on the OCT, and can see in the bottom right, can see how that loss correlates. And as Don mentioned, that some of that inferior field loss correlates with that there is some inferior macular changes going on that are being picked up. Right there, and going right onto the OCT. So
it's a great illustration of structure function agreement, isn't it? It's really the one of the things I've done when I try to teach people about this in a game you could play is you can give them the OCT and give them a blank field and ask them to predict the field, and vice versa. Give them the field and ask them to predict where the defect is.
Yeah, and here is the left eye, and we can see that for the 24-2, there's some diffused loss, and and the loss is greater inferiorly, which isn't as obvious on the OCT, but clearly that central loss, as we see down below, is nicely being picked up. You can see how dense that defect is, and can even see that there are even some points just below the horizontal meridian that then there's an area of a small defect that may also correlate too. So again, we're seeing this structure function correlation.
I have a question about this for you, Murray. Do you think those points that you're seeing on the visual field, like those the go to the 10-2, the ones that are below the midline there, to the left.
Yeah.
Yeah, right. Those. Do you think those are really below the midline as opposed to that you just have a slight tilt of where the raphe is?
I mean, that's a great point because, we used to think that horizontal raphe is this some magical horizontal line, and then now it appears that it's not necessarily that always that horizontal, and it could very well be that we're just that is just extending up a little bit.
And it's almost always in that direction too. It's almost always because of the angle. I think we're all at a slight angle, and it's almost always the case where you pick it up dropping below the horizontal meridian. Yeah.
And the other thing is that this field, the reliability wasn't perfect.
Right.
So I would want to, I'd want to confirm those points anyway. Hopefully, the individual gets to be a better test taker. But fact is, those points are moot because we know the glaucoma is the diagnosis, and we know that is significant, that the damage is extending into the macular region, and we need to reduce this eye pressure significantly either way. So the field would be to me in this case would be more useful going down the road if it ever progresses, to provide us with with room to monitor along with the OCT.
Good.
Okay, so in terms of the wrap up, here, this is a case of an individual with glaucoma with damage in both eyes, and get an idea of the excellent structure function correlation as we start to use the Hood report, going back and forth with the visual fields. With that, let me turn the program back over to Dr. Chaglasian, who has one other case to present.
For our final case here, I thought after looking at a couple of cases with more early stage diagnosis, I'd include a case of somebody who's been followed for a number of years with glaucoma, and just give us some opportunity to talk about this progression aspect that we brought up already, further discussion of structure and function, severity of disease. This is a 71-year-old patient who's had glaucoma for 4 years, primary open-angle glaucoma. There's been some poor follow-up and missed visits from the patient, so that's certainly a concern, and further education and reiteration of the severity of the disease is continuing to be done with the patient. Again, jumping ahead a little bit, the IOP is currently not at the target pressure, which is under 15 millimeters for each eye. The current medication is just a prostaglandin analog alone in the right eye and left eye. And there have been past trials of other medications, including dorzolamide timolol as an adjunctive agent, which did not further improve the intraocular pressure. The patient is hesitant and has concerns about further treatment, including when selective laser trabeculoplasty was discussed with the patient. So current vision in each eye is 20/25. The external exam is normal. There's no afferent pupillary defect. The slit lamp exam is unremarkable. The current pressures are 19 in the right eye and 19 in the left eye. So again, several points above what the target has been determined or set at. The pre-treatment eye pressure was 23 in each eye. And the pressure range over the past 4 years, again with sporadic visits and some missed follow-up appointments, has ranged between 17 and 23. Gonioscopy is open to scleral spur in each eye. Pachymetry is very low, 506 microns in the right eye, 512 in the left eye. And the corneal hysteresis, not quite as we look for low numbers with corneal hysteresis, it's 10 and 9.4. But I think overall the pachymetry findings would again be one of those risk factors, or at the onset cautious and concerned about this patient, and as we'll see how the disease has progressed over time. These are the baseline photographs. Sorry, they're not quite as good a quality as the earlier photographs I showed. They're disc only. They do show certainly large cupping and rim thinning, particularly infratemporally in the left eye here. where, don't go by the color, but by the vessel deflection there. And, you'll see that you would be able to see stereoscopically that there's a large inferior notch there. So again, that sort of sets the table for the clinician looking at the photographs or the clinical exam of the patient. Here is the early ZEISS reports, and we have a baseline OCT from several years ago. And then there were one or two other OCTs performed in between, but again, due to missed follow-up appointments and some a bad test scan that was acquired, another OCT 4 years later. And again, Don, you were mentioning about how you can just look, scan to scan. Maybe we can do that here. And I also have two TopCons, although they're not quite as far apart as these two ZEISS reports are. Looking at the thickness map for both the right and left eye, it's pretty obvious that the left eye has quite a bit of damage infratemporally. And as you jump over here to the later report, it looks like that damage has even increased temporally and also started to develop supratemporally for the left eye. And damage that was not present on the deviation or probability map for the right eye is now present on that right eye. Average RNFL thickness has also decreased significantly over this time period.
You can see if you go back for a second, you can see if go to the lower left-hand corner. Yeah, right there.
Yes.
Right there. See, go to the right a little bit. See all that tissue? No, to the right.
Oh, sorry. Yes.
Yeah, see that tissue there?
Yep.
Yeah.
And now it's not there.
Now it's not there.
Right. They do a pretty good job of hiding it for us down there.
Couldn't be any smaller.
Here's a fuller view of the ganglion cell analysis. Again, you have to leap from baseline to the follow-up exam, and then here to here. And, that's pretty evident. I don't know that you need the clock hour sector reports. You can look at the color maps, and I'll show you the progression analysis maps in a little bit. Here are the panel map reports, just again to reiterate that those are some of the reports that we're using more so. Clearly there's glaucoma damage here. Appears to be more severe in the left eye, but not far behind in the right eye. So this patient definitely has some concerns, and it was just a case that I brought up to, again, track someone over time and look at the severity. Here's the hood report from the TopCon instrument. And again, if we want to jump ahead, it's, on the probability maps, there's agreement. There's thinning on the Enston plot, thinning here on the B scan. It's evident on the ONFOS and the color map. So all of these things in this case, again, are in great agreement.
Yeah, this is great. You stole some of my thunder in my wrap up. I'm going to show something similar. But what you just did, if you go back for a second,
Yep.
What you just did is you use the same principles that it should be arcuate and everything should agree that we use for detection. You just use the same logic for progression.
Yep.
That is, if you just had one of these things changing, you wouldn't be convinced. But when you see them all changing in the same way,
Yep.
You've got progression, and you only had one follow-up scan on. Yeah.
Yep.
And here again, just to reiterate, everything is done, sort of in collaboration with other testing. Oh, here I think, you might, when you look at the field, this is high false positives. The clinician might want to dismiss this as artifact and poor testing, but it agrees with where the location should be. So, repeat the testing, get the patient to perform it better, and, it's not artifact on the visual field. Here's the left eye, and left eye with its visual field, more severe visual field loss, and again correlating. I don't think I have 10-2s. They certainly, could be helpful here. Sometimes in these more advanced cases, I tend not to do as many 10-2 fields on these patients. But, then there comes to be a point where the disease becomes more advanced and I have to do 10-2s in some of those very advanced patients. And finally, here's the layout for the TopCon. And again, I haven't had my TopCon instrument as long, so I only have 2 reports here from 2019 and 2020 showing some of that change in the inferior RNFL thickness, the circumpapillary RNFL, and it shows it there. You can see it on the color map there in the topography. I think you see a little bit less change for the left eye, perhaps because there's already more damage there, and it's maybe a little bit more difficult to see change on the OCT when you're getting close to that floor effect when you're down and already have severe loss. And finally, just if you're familiar with the guided progression analysis from Zeiss, you can see the right eye here and the defect I highlighted earlier, as well as a little bit of change on the ganglion cell. And then for the left eye, again, as I said, not much change here because we started at, if you look at the average RNFL thickness, 71, we've lost a little, but maybe there's still a ways to go on that, so we're not quite at the floor yet.
Can you go back to the previous slide?
Yep.
Yeah, I want to make, and let's just point to those wedges, in, the yellow and the red.
Yep, for the RNFL.
You know this, but I'm surprised that there are a lot of people who don't know what I'm about to say. If you have that yellow on exam 3, and exam 4 was identical to exam 3, no progression, no change, it goes from yellow to red.
Huh.
So red does not tell you it progressed. It just told you that that region has been significant twice for baseline.
It's sort of confirming it, but not indicating progression.
You're going from possible to likely, but there's no progression. And in fact, it's just the opposite. If you try it, fool it, put it in exam 3 again, and every place that's yellow will turn to red.
Yep.
Put in the same exam.
That's a good point. Not getting worse per se, just confirming that it's already there. Of course, it was clear enough on exam here, and this is when medications were added. Further treatment was continued to be discussed. Unfortunately, the patient's somewhat resistant to that, and
and the good news is whatever you're doing is working because it didn't change.
Let me give devil advocate to that, Don, because I don't mind that. Now, this is an extreme example where it's a huge wedge defect that developed.
Right.
But in many cases, the defects are far smaller,
right,
not as obvious, and to be able to confirm them a second time to a clinician is important. So,
no, I totally agree with you, Murray. Absolutely. I'm not criticizing what they're doing. I'm saying that it's misinterpreted by many.
Right. Exactly. Yes, it can. Yep.
Yeah. No, you're absolutely right. These little subtle things, you want that confirmed. Absolutely. Yeah.
Now, Mike, you want to just go back and just mention anything about the rate of change that you're seeing? That wasn't mentioned, and yet I use that information, whether it's the one thing that you see is the cup disc ratio. It doesn't provide a lot of useful information, but you do see that the rate of change, is what, minus 2.54 in average, and in inferior, it's way up there. You want, do you use that rate of change at all? Because that's something that is common for all of the different devices, that they provide some sort of rate of change as we monitor.
Yeah, those certainly can be important metrics. I think the normal average rate of change is about 0.5 micron per year, up to maybe not much more than a micron per year. So when you start to get 2, 3, and 4 times that, you're off the chart in how rapid loss is occurring to the retinal nerve fiber layer. And the goal obviously is to identify that as quickly as possible. As Don mentioned earlier, perhaps you can do it with just 2 scans. If it's a more subtle rate, you might, I don't know, Don, help me out here. You might need a 3rd or 4th scan there, but when you have these metrics, they can be reaffirming to the change that you're seeing.
Yeah, if you're talking about local changes like here, right? The images themselves, if you read the images themselves, the way you would read a CAT scan, MRI scan, you can see the tissue staying the same or changing. Using, it'd be the equivalent of if you wanted to follow a tumor in the brain and you were just taking some kind of an average measure.
But right, but this is an extreme case of when you see invariably over 7 microns of loss per year.
Yeah.
That's very fast progression, and that's but often they're far less than that. I would hope they're far less than that. We typically have used the half micron per year, and as normal aging. So I tend to use the number has to be greater than 1 micron per year.
Yep.
And you really need at least three of these before I think any of the devices can give you a rate of change. I mean, while you can always calculate one from the other, and I have read Don's paper, about changing, telling one for the other, and when you and the points made are huge or significant. I also just like to have multiple tests done over time when you don't see as rapid a progressor as you see here to get that rate of change, because there are times where the change is significant, but it's more diffuse, and this rate of change can be helpful.
Yeah, I think in this particular case, if you were looking at the images, you notice you only really have 3 points.
Yep.
Right. And so what happened between baseline and exam 3 is you went from a lot of tissue in the inferior temporal to a serious loss of field cut. Right.
That's a 4-year time period.
Right.
Yep.
And so if the images here would knock your eye out, if you looked at the circumpapillary image in the baseline, it would be nice and pudgy and look reasonably normal. And you basically have almost nothing left in that region by the time you get to exam 3.
Yep.
Yeah. And the last point I would just make on this is simply that for this case would want to reset the baseline and make exams 3 and 4 the baselines, just because of the change from there.
Absolutely. Okay.
These are the fields. We've already been through those. And I think that concludes our case presentation. Don, I'll turn it back to you.
Okay, that was great. Thanks, Mike, and thanks, Murray. And now let's see what we have from the audience in terms of questions. And again, if you're really fast, you can add a question, but I see we already have some interesting questions. Okay, well, let's take a look at some of these questions. So here's one. How reliable is the retinal nerve fiber layer thickness of the maculopapillary bundle? Would a lower level always indicate an optic neuropathy? And the answer is that's related to the last thing I think we were discussing in the last Q&A period, where I said the toughest thing to diagnose is often maculopapillary bundle damage, which is another way of saying what I was saying. So if your retinal nerve fiber layer is down in that region, and you also see something on the ganglion cell, is that anatomical variation, or is it optic neuropathy of some kind? And if so, what optic neuropathy? So here's where you have to look at the rest of the report, the B scan and the circular B scan and the accompanying thickness map should be in the temporal region, down in the yellow or red. If it's in the green, it's probably just anatomical. But you're going to have to look carefully at both the fundus photo and also at 10-2. Again, this is one of the more difficult situations. I don't know if either of you want to add anything to that.
Yeah, well said.
No.
Okay. All right. Can you make decisions based on the visual field since it's not reliable? I think this came in during the case presentation. So I'll leave this. It's a clinical question anyway, so I'll leave it.
Yeah, I'm not sure which case that was referring to. Perhaps a couple of the fields within those cases were unreliable. But again, it's in the context. If something is clearly, highly unreliable, then no, you can't use it. But sometimes there are marginal unreliability parameters that are flagged where there still might be some usefulness. Of course, it's always best to repeat it and confirm it. But if your other evidence, I would suggest, is pretty strong, then you can still make a decision.
Okay, and then this next question has to do with the first two cases. Did you start treatment the same day for these two cases, or did you wait for some kind of verification and repeatability?
Well, I think both cases, perhaps testing was spread over 1 or 2 visits, as is typical for me. I mean, I rarely find it necessary to start glaucoma treatment on the same first day as a visit for a patient, unless the pressure is extraordinarily high and the patient is at very high risk for immediate vision loss. I'm not also always waiting for repeatability, although that's sometimes necessary, but I'm waiting to reconfirm eye pressure measurements at different days and different times, and collecting all the data that is sometimes, frankly, just too much to collect in one single visit. So I think the clinical statement would be, I don't typically start on the first visit for most of my patients.
Murray, anything you want to add to that?
No, I think Mike hit it right on the head. I rarely will start on day one unless, as Mike said, the pressure is really high. Would like to get at least 2 and sometimes even 3 untreated eye pressure readings. And you often, you'll dilate on one test and then do a field to do something else on another visit. So it's difficult, and especially now in the COVID era where you're trying to get people in and out quickly, that often will limit how long a person's in the office and limit the testing.
Right. Here's an interesting one, actually, that do you use asymmetry between the eyes to help with diagnosis? And so let me answer first and then ask the two of you. I don't use anything formal about asymmetry in terms of thickness, although the similarity between the two eyes is greater than the similarity of one eye to another individual. So there's information. The place I have found it particularly useful is in what some people call green disease, which means that you have a defect, but nothing's shown up red on your metrics, because you have a decreased thickness, let's say, on the circumpapillary thickness map, but it's still in the green. Because remember, most of us start out in the green. If we get glaucoma, you're going to have to work your way through the green before it becomes abnormal, right? And it's not uncommon to be able to pick that up, especially if you have visual field evidence as well, by comparing it to the other thickness to the other eye. How about you guys? Do you use asymmetry at all?
Yeah, Don, one of the open angle glaucoma is an asymmetric disease, and it's asymmetric between the two eyes, and that one eye starts before the other. And 2, even in the same eye, you see damage in one hemifield greater than the other as it starts to develop. And the question often asked, Michael, I'm sure, gets the same question as me. Somebody presents with damage in one eye and they say, why don't we just treat one eye and not the other? And the answer I give is it's a bilateral condition, but it tends to start in one eye. And I unless I see a reason like trauma or angle recession or perhaps exfoliation, I will consider this a bilateral condition. So, I think in regards to the OCT, I agree. We talk about the 5 micron or something like that, and those rules I don't think work. But asymmetry is, I find, or I use, as you say, as even to rule things out.
Okay, great. Well, I think that does it for this time period. And this is our last Q&A. I just want to, I think on behalf of all 3 of us, to say the questions have been sensational, and thank you for submitting them. And now it's time for a wrap up. All right, so I'm just going to take a couple of minutes to wrap this up and make a few concluding remarks. I want to go back over where we started, because I think we have some nice examples of the 4 principles. I want to go back over the 4 rules and relate it back to a few of the points that were made. So you want to examine the circumpapillary image for glaucomatous damage and segmentation errors, And let me just give a little commercial here. You know, we are so lucky to have this OCT technology. It is phenomenal. And those of us who lived before it, I think really appreciate it. These images that you can now get have 100 times the resolution of a CAT scan or an MRI scan. But we're not always making use of it. We have to be looking at these images, right? It makes no sense in this day and age not to look at the actual image. And so in this case, what we're going to be looking for here is segmentation and also possible damage. Rule number 2, you need both ganglion cell and retinal nerve fiber layer probability deviation maps. So I'll remind you that this was the retinal nerve fiber layer probability map. This was the ganglion cell probability map, both in field view. And whereas these are the thickness maps. Rule number 3, we want to look for topographical agreement of glaucomatous damage. We're looking for arcuate patterns and everything should agree. So these red arrows are all topographically in identical places. The black arrows are in a different location, but topographically in agreement with an arcuate defect. All right, so let's go back and illustrate, patient 1 was one of the many that we showed today that illustrated the rule number 1. So you take a look at this and that's clearly extremely thinned. That's going to be a fairly deep field cut. In terms of segmentation errors, we noted that we could relate this to this by just taking a look at the segmentation error. And all algorithms are going to make mistakes no matter what the manufacturer is. All right, we're looking for topographical agreement of glaucomatous damage. So as I pointed out earlier in this session, you're looking for agreement between this and this. You don't have to superimpose them, but if you do, you're going to get something like this. That is optic nerve damage. It's very hard to reproduce that with a artifact of some kind. So the important insight here is this kind of an agreement is almost certainly optic nerve damage. Rule number 4, if you want to compare visual fields, which is often the case, you want to use deviation maps in the visual field, not mean deviation, pattern standard deviation, or glaucoma hemifield test. So in this particular case, we were worried whether this was due to a real defect or blood vessel location, right? Because the peak was here and the vessels usually are over there. And so we're looking for abnormalities here. So we're not just going to look at the whole visual field. We're going to look at these regions here, which you can see confirm that this is probably a healthy eye. I want to end by making a point that Mike actually brought up, and that is the same logic that's used for detection. We haven't talked about progression, but that's the other problem as clinicians you face. Is the eye progressing? The same logic can be used. Whereas if you just had this and you went to here, this may look a little thicker, a little worse, but you can't be sure. That could be an artifact. But when you see it happening every other place, you know you've got progression. So one thing you can actually do is flicker between these. So what I want to point out is no matter where you look, you can see progression. That's getting wider. That's getting wider. The defect's getting wider, right? This is changing. That's changing. That's changing. You have progression. Here's another example. Same thing. No matter where you look, there's topographical agreement. So I want to end by thanking, first of all, Murray and Mike. It's been great working with you. And I think this was an excellent session because of the expertise that you brought as well as the spirit. I want to thank TopCon Health for the eyeRISE series in general and for this session in particular. And most importantly, I want to thank those of you who tuned in. Thanks again.